wide so that the premolar can erupt through that loop. It should follow the alveolar ridge pattern. At the same time, it should not impinge your gingiva, and it should be in close approximation with the alveolar ridge. The distal shoe space maintainer. Whenever there is an early loss of your second primary molar and the young permanent molar is in active eruption, before the age of 6 to 7 years, you need to give a distal shoe space maintainer. In this particular space maintainer, we will band the first primary molar and a distal shoe is fabricated, which will guide the young permanent molar in its final position. So such that the young permanent molar doesn't come mesially and it doesn't block the second premolar. There are few contraindications of this distal shoe space maintainer. It includes systemic diseases like diabetes mellitus, where healing of the extraction space can be compromised if you put any kind of foreign material into it. Healing in diabetes mellitus patients, it takes longer period of time and some kind of secondary infection can also take place. At the same time, patients with systemic disorders like cardiac anomalies, where the risk of secondary infection is always there. In those patients, better you avoid a distal shoe space maintainer. Then, whenever there is inadequate abutments, you don't have enough tooth for banding procedure. At the same time, the stability of that appliance is a question mark, then such cases are contraindicated. Poor patient and parental cooperation. The patient is coming back with the appliance after 2 to 3 weeks in his hand. He is eating all kind of chewy food. He is not able to maintain oral hygiene. He is not following your instructions. Those patients who are not motivated for that appliance are a strict contraindication for a space maintainer. Coming to the concept of preformed space maintainer. They are single visit and very useful in sedation cases. Whenever we do child patient under general anesthesia, under IV sedation, under nitrous oxide sedation, there is a very little scope to do the banding, do the wire bending, and fabricate the appliance inside the operation theater during those 2 to 3 hours time period. So you need something which is ready-made. Then in this concept of ready-made space maintainer, you don't require to do any kind of impression making. There is no laboratory work. So laboratory errors also can be avoided. It can be done in the same appointment. In India, I don't know about Zimbabwe, but whenever we give a chance to the patient to think and go back home, most of the time when the primary symptoms which are there, if they are taken care of, they don't come for the other treatment. Say the patient has a swelling in the primary molar and we have advised extraction and a space maintainer. So once the extraction is done, the patient generally never comes back for a space maintainer thinking that the permanent tooth is eventually going to come. But here in the same appointment of the extraction, we do the space maintainer. So even the parents are not left with a choice of not getting ready for a space maintainer. In a normal customized space maintainer, there are various steps. You take an impression, you stabilize the band, you pour the cast, where many kind of error can take place, like the band can change the position while pouring the cast. Then wire bending is done, the shouldering procedure is done. At that time also, the wire can be 0.1, 0.2 millimeter short of the canine or the D where you are giving the space maintainer. So such kind of errors can be avoided with a preformed space maintainer, where you have a scope to modify that space maintainer intraorally before cementing that space maintainer. In distal shoe space maintainer, we are totally relying on that IOPA. You measure the mesiodistal width on the IOPA, then you make a groove on the dental cast and you tell the laboratory person to make the distal shoe space maintainer on that particular groove. So if there are errors in that IOPA, there is some kind of elongation, then those errors can take place and there is no scope of modifying your space maintainer once it's fabricated in a dental laboratory. Now coming to the technique, how to do this preformed space maintainer. To learn how to do this space maintainer, we will first see the system of a preformed space maintainer. So this system of preformed space maintainer contains band with the attached tube. The bands are from the sizes 24 to 42. The 24 to 29 number are smaller size bands for your first primary molar. Then from 30 to 35, they are used for your second primary molar. And from the 36 to 42, they are used for banding of your young permanent molar. The bands in this system of e-space maintainer are universal bands. By the word universal, I mean there are no left, no right, no maxillary or mandibular band. The same band form can be adjusted on all the four sides of a dental arch. So that way you don't need to buy right side, left side, maxillary or mandibular bands. Along with this, there are three types of components. One is a straight loop, the second is a curved loop, and third one is a distal shoe. There are two pliers. One is a crimping plier and second is a special cutter to cut the components and to adjust the mesiodistal width. Along with this, you might require a band remover, a hole plier, a band pusher, and a band adapter. Sometimes you will need a greenstone burr or a disc to cut the wire if you don't have a special cutter. So this band has an attached tube. The tube has 0.8 millimeters of width. And the wires are made up of 22 gauge wire that is 0.7 millimeters of diameter. If you want to give a band and loop space maintainer, the step one is to band the tooth. After banding the tooth, you calculate the mesiodistal width of the extraction space. That mesiodistal width is transferred to the component wire and you cut the wire according to that mesiodistal width. That wire will go inside the tube and you try to place that space maintainer in the patient's mouth. If that wire is not going and the canine is coming in between, you will cut more, 1 mm more and try to place that wire in that mesiodistal width. When everything is perfect, the position is perfect, the band is adapted properly, you take the crimping plier and you squeeze that tube. Once you squeeze that tube with the wire inside that tube, you will lock that wire inside that tube. This is called as cold welding. Once you do the crimping part, you have of that tube and you can cement that space maintainer. What is the technique for a distal shoe space maintainer? Similarly, you do the banding of the first primary molar. After this, you measure the mesiodistal width of the extraction space. You mark that extraction space on that component. You cut that distal shoe according to the extraction space. That distal shoe wire will go inside the tube. You will again put the band in the patient's mouth and you will take an IOPA to check the position of the distal shoe if it is guiding the young permanent molar properly. After that, if it is in a proper position, you will crimp the tube so that the wire gets completely engaged in that tube and you lock it over there. So this is the position of that distal shoe space maintainer. In the IOPA, you can nicely see how this distal shoe space maintainer has guided that young permanent molar in its final position. So I told you we are using a universal band form. So this is how you do the banding procedure. So here the rectangular form of band, I am trying to squeeze it proximally to make it squarish form so that I can easily band a maxillary primary molar. After this, you use a band adapter to adapt the band on all the four sides. Now I try to remove this band. To remove the band, you can either use a spoon excavator or a band removing plier. Always while removing the band, you should control the band from the other hand so that it doesn't get displaced inside the patient's mouth. Now I am trying to use the same band form on the contralateral side. See, it is not going over there. So what I do is I squeeze the band in the two opposite line angles so that I convert a right side band to a left side band. To make a right side band to a left side band, I will squeeze the mesiobuccal line angle and the distolingual line angle, the contralateral line angles. So now you can see after I use the adapter, I have completed my banding. So the same band can be used for left side as well as right side. Coming to the component. The component should be cut at the same level. At the same time, both the wire forms should be parallel to each other. If the wire is not able to go inside the tube, you can use any universal plier or a hoe plier to push the wire inside the tube. The wire one end of the wire is cut at a higher level than the other end of the wire over here. So this will not go easily inside the tube. The wire 2 which is there, both the wires are not parallel to each other. Again, you will have difficulty in putting this wire inside the tube. But the wire 3 is cut at the same level. At the same time, both the wires are in a parallel position, which is an ideal position for the wire to go easily inside the tubes. To cut the wire, there should not be any blur or flesh around this end part of the wire. If there is some kind of a blur or a flesh, you will need a greenstone burr to smoothen it up. was the video demonstration of how to do a preformed space maintainer. I would like to share some few clinical cases. So this is a band and loop space maintainer in the lower region where the first primary molar was extracted. After extraction, we generally give a 15 minutes of a pressure cotton pack. Then bleeding is controlled and you start with the space maintainer procedure. Here you can appreciate the crimping of the tube which has engaged the loop part. Same case on follow-up. This is the radiograph of this patient. So here you can appreciate how much the wire goes inside the tube. You should always crimp towards the open end and not towards the joint, because towards the joint there will be some dead space. So if you try to crimp the tube part where there is no support of wire inside, you will cut the tube. One more case of a band and loop space maintainer in the maxillary arch where a straight wire has been used. So some latest research says that you don't need to engage the canine completely. So if you engage the canine in the proximal surface like a bird's beak, then you will restrict the movement of the canine during the lateral growth of the jaw. That's why only a point contact with the canine should be there. So it is up to the clinician to choose a straight wire or a curved wire. One more case of lower D extraction and a preformed space maintainer. Here you can appreciate the crimping part. Then extraction of the lower E, the permanent molar was there. We banded the young permanent molar and the band and loop space maintainer was given. This is again a case of lower band and loop space maintainer. You can also, to measure the mesodistal width, you can measure the extracted teeth which is there. And accordingly, you can adjust that wire. One more case of band and loop space maintainer. So here the advantage is you save a lot of time and you complete everything in single sitting. Here again, some doctors want to crimp 2 to 3 times in that tube. Some do crimping only once. So 1 or 3, both will have same kind of clinical results. It is up to the clinician to do single time crimping or 2 or 3 times crimping. This is a case of upper band and loop space maintainer. One more case of band and loop and the customized space maintainer in the same patient's mouth. Cases of distal shoe space maintainer. Here a distal shoe space maintainer has been given in the maxillary arch and you can see how nicely the distal shoe can guide the young permanent molar. Here you have the scope to change the position of that distal shoe inside the tube. So once you confirm the position of that distal shoe according to the young permanent molar which is erupting, then only you do the crimping procedure. So you know exactly where my distal shoe is going to lie. A lower E extraction and a distal shoe space maintainer. A lower E extraction and a distal shoe space maintainer. A case of band and loop space maintainer over here. After the extraction of the D, the same day this space maintainer was given. You can appreciate the universal bands. They have so nicely adapted to any kind of tooth shape. It does that you just need some minimum adaptation over the tooth according to the shape of the teeth. You save on inventory and you save on dead stock. One more case of distal shoe space maintainer. And here you can see in 8 to 9 months time how nicely this distal shoe space maintainer has guided this young permanent molar in the proper position, which was already trying to erupt mesially. So don't over crimp the tube. It can cut the tube if there is no support of the wire beneath it. Always keep the wires parallel and you can use a hoe plier to insert that wire inside the tube. There are many advantages of this preformed. You save a lot of time. There is no impression making. The same anesthesia, you can do the banding procedure. Your patient will be comfortable. These space maintainers are economical when you compare to a laboratory made space maintainer. And for a distal shoe space maintainer, you can finalize the position where you want the distal shoe to be there, rather than relying on your IOPA and your lab person to judge the position of the young permanent molar and accordingly make the space maintainer. There are few adverse effects, like you are doing it in the same appointment of extraction. So you can see some gingival growth over the space maintainer, but you can remove it when the premolar is trying to erupt by just giving some infiltration anesthesia over there. Sometimes there will be a cement failure and the position of this band and loop space maintainer can change. That time you can re-cement it. If the patient is not maintaining the hygiene properly, there can be secondary decay. There can be decalcification. For that, you need to motivate the patient, give proper instruction, and a follow-up is a must. On recall appointment, what do you generally check? You check the fit of the space maintainer and you check the position of the premolar. You take an IOPA. And in our practice, what we follow at 6 months, if we see that the patient is not maintaining the hygiene properly, we see some kind of decalcification, we'll remove the band, we'll apply the fluoride, and we will re-cement the band. If the hygiene is proper, then no need of removing the band and re-cementation. What does the research says? The research says that a customized space maintainer versus a preformed space maintainer. A preformed space maintainer is more rational and cost effective than a conventional one. I've been very lucky to travel the world, to take workshops, to do patients. These are photographs from Vietnam. This is my trip to Iraq. I've been to Egypt. I've been to Kenya also. I've been to South Africa. In South Africa, I have met few dentists from Zimbabwe. I've been to Kenya. This is my friend from Kenya. I've been to Georgia for lectures. This is my company, ZiDA Dental. We manufacture exclusive pediatric dental products, and we try to make the work of a pediatric dentist easy, because managing a pedo patient is very challenging. So we try to find solutions for the same. So this is the clinic where I practice. I do exclusive pediatric dentistry. Thank you for your patient listening. This is my email ID. One more question in everyone's mind right now is, we learned a new technique, but is this appliance available in our region, in my country?